Now we're going to talk about birth control. I often talk about different forms of birth control, and my patients are sometimes confused. So let's dive into it. Let's talk about the two categories of birth control, non-hormonal and hormonal contraception. In terms of birth control, we'll start off with the least effective, and then we'll go up to the most effective. The first is fertility awareness-based methods, meaning some sort of calendar where you're trying to predict when you're ovulating. This is the least effective because about 24% of patients may end up pregnant. The next category are the hormonal contraceptives. That includes the pill, patch, ring, and also the injection. About 6 to 12 out of 100 women will likely get pregnant within a year of starting these, and that's even with perfect use. The way I explain the hormones is that estrogen is like watering the grass. So estrogen is going to make that lining in the uterus grow, and progesterone is like a lawnmower where it makes the lining thin out. So when your doctor is adjusting your birth control pills, that's what they're adjusting, either the estrogen to make the grass grow, meaning make the lining thicker, or they're adjusting the progesterone. They might increase it to make the grass thinner. So now let's go to the other options. The first is going to be the injection. And the injection, it's convenient because you come back to the clinic every 3 months, you get an injection, and then you go. Then there's the patch where you place the patch on this arm or this arm and you alternate each week. And then that last week, you take the patch off, and that's when you start your period. The ring is similar, where you place the ring inside the vagina, you keep that for 3 weeks, and then you remove it the last week, and that's what stimulates your period to come on. So all of these contraceptions, all of these birth control options work similarly. At the end of that cycle, you remove the stimulus and then you have a period. With the pill, you take the pill every single day. Remember I talked about the one with estrogen and progesterone. That one you take every day, but if you miss a day, you can double up on the pills the next day. However, if you miss 2 days, you can't double up. Now, for the pill that's progesterone only, you have to take it the same time every day. The patients who typically do the progesterone only pill, they either can't have estrogen, so let's say they have current breast cancer, something like that where you don't want estrogen there, or maybe they're breastfeeding. The data does show that progesterone only pills are better suited for patients who are breastfeeding. So that's the caveat with the pill. Our top layer is going to be our long-acting reversible contraceptives or sterilization or tubal ligation. In this group, 1 in 100 patients will be likely to get pregnant. The way I explain this category, it's the most effective, and they're all on the same line in our ACOG contraception chart for a reason. All of them have a rate of failure that's less than 1%. The range is about 0.2 to 0.8%. The reason why they're all on the same plane is, let's say you're trying to decide between surgery, bilateral tubal ligation, and these other options. You may opt to pick the more conservative option versus going through anesthesia, having incisions made on your abdomen. So what are those long-acting reversible contraceptives? The first is called a Nexplanon or an implant. It's placed right underneath the arm, and the reason why this one is special is it lasts 3 years. And when I do the procedure, you get some numbing medication and you're pretty much in and out within 5 minutes. And that stays there for 3 years, like I said. This one just has progesterone, just like the other ones. And then let's talk about the IUD. There are different types of IUDs ranging from lasting 3 years all the way to 10 years. The first is Skyla, which is a smaller IUD, and we usually use that for women who have not had any childbirth. So it's for that patient with the cervix that's tightly closed, and that's for 3 years. Then we have the Mirena IUD, which is the most common IUD. That lasts for 5 years, and some women up to 6 years, but definitely come in if it's been 7 years. And that contains progesterone, and it looks like a T-shaped device. And similar to when you get your pap smear, we place the speculum in the vagina, look for the cervix, and then we insert the IUD. Again, that's a short procedure, about 5 minutes. And then when you're ready to take it out, you come back in 5 years and we take it out. Some of the side effects of the long-acting reversible contraceptives include bleeding. So the most common is bleeding. And I typically counsel my patients to give it about 6 months to a year, because many patients, they end up having a very light period or no period at all. And one of the misconceptions is that you have to have a period every single month. If we know the reason why you're not having the period, meaning you're doing a hormonal contraception, that's the reason. So there's not typically a concern there. Let's move on to our permanent contraception, which is the bilateral tubal ligation or sterilization. And basically what we do is we take a segment of your fallopian tube, we tie a suture there, and then we cut right above it. And then we cauterize, meaning we burn the stumps that are left. And that is very effective. So that's available for all women. The last caveat I want to make is that sterilization is not just for women. There's also vasectomy that can be done for men. It's kind of like an asterisk in the office, but it is an option. So not all of the burden and the responsibility needs to be on the women. Have that discussion with your partner. Men can have sterilization procedures too. It's called a vasectomy. The best next step is to talk to your OBGYN about these different options and how they might fit in with your lifestyle. If you want to learn more information about women's health, make sure to subscribe to my channel.